Thanks, Jill. So unlike our previous guest speaker, Raza is absolutely rubbish at football. But he loves watching it and eating crisps while he's watching it. So he's a lover of football, but rubbish at playing it. But he's a great colleague, incredibly knowledgeable. He writes all our guidelines. He's been involved in randomized controlled trials for anticoagulants. And he's also, the most important thing of all, he's actually got common sense, which unfortunately not everyone is blessed with. So it's fantastic that you can share your sort of thoughts with us, Raza, and I'll hand over to you now.
Thank you very much, Will. It's always a pleasure to come and speak and have an opportunity to teach as well. When I got the invite to talk about how I treat thrombosis and try and distill 25 years of experience into 20 minutes, I was a little bit concerned, and I wanted to make it very sort of clear and targeted towards our audience of newly qualified doctors. But actually, I think, Holly, you've done the trick really. You basically summed up why this is so important. Jill mentioned at the beginning, we all come across patients who suffer a thrombotic event. It doesn't matter what speciality we go into, we'll all come across patients. And I think it's important that we consider the diagnosis, whether or not we're in a big hospital, we're in a GP practice, or we're out working in the community. I think it's really important to consider the diagnosis. Now, hopefully, you can see my first screen. I'm hoping, yeah, I see a thumbs up, so that's great. So I'm going to sort of whiz you through how I treat thrombosis. And again, this is aimed at the junior doctor treading the boards for the first year or two, and just trying to get you to think how you might manage a patient. And just to sort of stress why it's so important, the risk in the adult population is about a 1 in 1,000, but that risk tends to go up with age. And we tend to use sort of age 40 as a sort of point of reference where your risk is 1 in 1,000. Whereas when you sort of hit 80, your risk goes up to perhaps 1 in 100. So you double your age, but you increase your risk of having a thrombotic event tenfold. But as Holly just proved to us, these clots occur in younger patients. We see them in teenagers. We see them in patients in their 20s and 30s as well. And there's a disconnect between DVTs and Ps. We're talking about venous thromboembolism, so blood clots in the legs, blood clots traveling from the legs into the lungs. The majority of the clots tend to occur in the lower limbs. About 80% of all DVTs will occur in the legs. And so I think that's just worth bearing in mind. And just taking some of our students and junior doctors back to medical school, Rudolf Virchow described his triad. He's the sort of the father of modern day pathology. And he actually coined the terms thrombosis and emboli, describing them from his work on venous stasis. And in fact, World Thrombosis Day is next week. It's actually on the 30th of October, which marks his birthday. So this is a timely presentation in terms of what's going on. And for those of you who perhaps didn't quite understand the importance of Virchow's triad, here's just a reminder of some of the risk factors that are acquired, inherited, that may contribute to the formation of a blood clot. So you have physiological factors. Pregnancy is a very important risk factor. I've touched on age. Malignancy, we're going to talk about non-cancer associated thrombosis today. And then medication, of course, estrogen containing contraceptive devices, but also medication that we use to treat our cancer patients. And then there are other causes, surgical causes and acute illnesses, acute infection, acute heart failure, and of course, respiratory infections we now know, well, we have known for a while, but particularly at the moment, we see viral respiratory infections being associated with thrombotic events. Now, from medical school, you'll remember that arteries are red and veins are blue, so that always makes it easier to diagnose where a clot is. But there are blood vessels all over the body, and I have to confess that when it comes to veins, there isn't a vein I haven't seen a clot occur in. But the key here, and I just want you to take a moment just to look at this slide, is, as I said, 80% of all clots occur in the lower limb. And all that time we spent teaching you anatomy, there was a reason for it. So I'm going to make no apology, just to do a quick refresher and just remind you how important it is to understand the anatomy of the lower limb. And one of the reasons why it's important is when you send a patient off for a scan, you'll often get a report back telling you which vein the clot is in, but they won't tell you whether or not you should be treating that clot. And so if we take the knee as a cutoff and we think of below knee as distal, so distal veins, there are 3 pairs of veins, an anterior and posterior tibial vein and peroneal vein. So there can be up to 6 veins that all come together at some point, and where they come together to form one vein, that is the popliteal vein, okay? And those veins below the knee or before you form the popliteal vein are known as calf veins, okay? It's like spaghetti down there, okay? And many guidelines, nice in particular, say don't look for the spaghetti clots. You can ignore them because the risk of a clot there traveling to the lungs is low, okay? But it's important to know what those veins are and what they're called. Once you get into the popliteal vein, we're talking about proximal veins. We hear about above knee veins, and the popliteal vein connects to the common femoral vein via the superficial femoral vein. And the reason it's called superficial femoral is that anatomically there is a deeper vein, a deep femoral vein, but it is the superficial femoral vein that is the highway between popliteal, common femoral, iliac, and then the lungs, okay? Obviously there's a bit of IVC to go through as well. If you get a clot in a proximal vein and you ignore it as a doctor, there is about a 50% chance that clot ends up in a patient's lungs, okay? And this is just a really important point. So when you get that scan report, look to see where the clot is in which vein to help you decide whether or not you should be treating the patient, or can you afford to bring the patient back in a week to re-scan them. Okay, and the reason that we worry about blood clots in the legs, as I've already alluded to, is we worry about them breaking off, traveling to the lungs, just as Burkhoff described with his emboli. But there are other things just to take into account. I think, 1 in 3, maybe 1 in 4 patients who develop a deep vein thrombosis in the lower limb will go on to have chronic problems. They may turn up with just pigmentation, so the top left-hand box. It might be minor, it might be just a few blue or purple thready veins, venous ectasia, just maybe a little unpleasant to look at, or there may be more pigmentation. All patients turn up with chronic pain, hard, woody, tender skin, itchy skin, right up until the point where they may develop ulcers, particularly around the medial malleolus. So post-thrombotic syndrome, very well recognized and well described. But what we're beginning to see more of now, and is being described more, is this post-PE syndrome. So not just after DVTs, but this post-PE syndrome. And I was in clinic this week and had a very interesting conversation, again, with a very young patient. And she described ongoing feelings of anxiety, episodes where she would become breathless, and then become very anxious. And she was wondering, and she was concerned about whether or not she was developing another blood clot. And there were a number of, hold on a second. Oh, computer's just about to switch off. That's a new one on me. Okay, yeah, good. Helps if you turn the plug on. Okay. So things to consider when you see patients who've had PEs over the last 3, 6 months or the past year. Has the patient developed chronic thromboembolic pulmonary hypertension? That's the thing we always teach and we worry about. But that's probably only 1 in 20 patients who are developing these chronic thrombotic events and developing high pressures in their lungs. There are other things going on. We're having functional impairment. The patients are deconditioning, they're anxious, there may be strain being put on the right ventricle. And these patients need assessment because this is a really important cause of morbidity for our patients. I'm going to, again, when I teach our medical students and when I carry on with the presentation today, I'm going to be focusing on how we diagnose and we anticoagulate our patient. But the things that Will and Jill and any of us do is at our 3-month and 6-month reviews, we're trying to assess the ongoing care for our patients because of the stress that the blood clots put on them. So we're always worrying about mortality, how many patients might die from a blood clot, but actually it's the chronic morbidity that I'm more worried about in the long term. The depression, the anxiety, the impact it has on the patient and their family, their work life, the recurrent presentations back to hospital. and potentially if you develop very, very rare complications, there is a mortality risk as well. So I think it's really important that we concentrate on making the diagnosis and treating the patients acutely, but we don't forget about the patient's journey beyond. Okay, so I'm going to just present a very general case. I was going to say this was a young man, but now that I've heard Holly, I feel extremely old. So this is a gentleman in his 50s, so about Will's age, I think. But obviously Will's aging much better than I am. So he presents essentially, he's had a recent trip abroad, got a little bit of high blood pressure, and he's had a swollen calf in the last couple of days. And he's the kind of patient that you could see in any clinic or on a home visit, in primary care, in the emergency department, or an outpatient. Very non-specific symptoms. And this is, this is the patient. I showed this scan to my wife. She's a nurse, and I said to her, "Would you think that patient had a DVT?" And the only thing she pointed out to me were the condition of his nails, which I thought was very interesting. I think he possibly has a bit of fungal infection, which I didn't pick up at the beginning. But there's a little bit of redness, I'd like to suggest, and a little bit of swelling in the left leg. So he's got a calf swelling, but the signs are subtle. And the symptoms and the differential diagnosis for blood clots in the legs and in the lungs is extremely challenging and wide. And so you've got to have your wits about you. Okay. Now, busy slide. This is from the new NICE guidelines. Basically, if you suspect a DVT, do a risk assessment, a pre-test probability score, the world score, and it's called a 2-level score. The reason it's called 2-level is because the clot is either likely by the risk score or unlikely. And so if it's likely, so just to remind you, you can find the risk scores. In the old days, Will and I would have learned these off by heart, but now you pull your phone out, you go to MD Calc, and you get your app and you just type all the bits in. And if you score 2 or more, it's DVT likely, and you proceed on to imaging. If, however, it's DVT unlikely, you go down the right-hand side, you do a blood test, a D-dimer, and if that's positive, again, you go on to imaging. And so I'll show you the patient scan, and I apologise that the video is not working. On this scan, it's not normally labelled for you when we do the scan, but just to show you where we are. If you start at the top and work yourself down, so the top we've got skin, subcutaneous tissue, then we've got muscle, and then you've got some black circles in the middle. On the left-hand side, there's a vein, and on the right-hand side, there's an artery. And we use colour flow. So on the video, you would have seen the pulse in red, because remember, arteries are red, and then you would have seen some blue on the colour flow on the left-hand side. And essentially, on the left, well, in fact, you can see a little bit of red and colour flow on the right-hand side in this image. That's the artery. And then there is a filling defect. There's an absence of compression. And what I show you here is the actual report that was produced by the lab, and that was then presented to the on-call medical team. So there's an absence of compression and flow within the superficial femoral vein in keeping with acute thrombus. And then the last line, and this is the line that was read out to the consultant by the junior doctor on the post-take ward round. No evidence of DVT within the popliteal, common femoral, and iliac vein. And you won't be surprised to hear that the busy team sent that patient home and reassured them that they did not have a DVT, okay, because there was no clot in the popliteal, common femoral, and iliac vein. There was some superficial clot. That's what the consultant was told by the junior who looked at the report. And I'll take you back to your anatomy from your first and second years at medical school. The superficial femoral vein is connecting the popliteal vein to the common femoral vein. It's like the M4 from Cardiff to London. It is a direct route to your lungs, okay? And so thankfully that patient, we picked this up within 24 hours and brought that patient back. But I would suggest that this happens once or twice in every hospital across the UK, if not wider. So if you take nothing away from my presentation today, it is please just go back and remind yourself of the anatomy of the lower limb. That is where the majority of the blood clots, the DVTs that you're going to see are, and just remind yourself of where those veins are, okay? Now, treatment. The initial treatment is extremely important. That first week, that first month is the time when your patient is most likely to have another clot, a recurrence. So it's really important that we get our treatment right initially, first week, first month. After that, for the next 3 to 6 months, we are still treating that acute clot, and we are still trying to prevent it extending, embolizing, or reoccurring. Beyond that period of time, any treatment that we give to our patients is designed to reduce the risk of recurrence. We are no longer treating that initial event. We are trying to prevent. We are looking at the future. This is secondary prevention. Okay, so that's important to bear in mind. Now, the NICE guidelines that were published last year recommend rivaroxaban and apixaban for patients with DVT and PE, but there are also other treatments, low molecular weight heparin, warfarin, dabigatran, and doxaban. Okay, and as prescribers, I just want to spend a minute or two just reminding you how to prescribe these drugs. So if you're working in a hospital where you use rivaroxaban, it's 15 milligrams twice a day for 3 weeks. And we advise patients to take that with some food because it aids absorption. And then after 3 weeks, the patient steps the dose down to 20 milligrams daily, again, for at least 3 months. If you're using apixaban, it's 10 milligrams twice a day for 7 days for that week. Then they step down, but they carry on twice a day. Again, 5 milligrams twice a day for at least 3 months. And I would suggest and encourage you that when you see these patients and you counsel them and you start them on their anticoagulant, that you provide them with the full 3 months treatment, that you don't rely on the patient trying to find a GP who can make an appointment in 2 weeks' time or a month to give them a new prescription, because patients often, particularly some PE patients, start feeling better within a week or two. And if they start feeling better and you're only giving them a 2-week prescription with their antibiotics and they start feeling better, they stop all their treatment and they come back with a recurrent PE. So it's really important to make sure the patients are counseled at the beginning. And we signpost all our patients to the Thrombosis UK website, particularly in terms of advice on exercise and when to exercise and how to exercise. And there's some great videos that I would encourage you to look at on the website. If, however, you're not using rivaroxaban and apixaban, then if you're using dabigatran and edoxaban, it's important that these patients get at least 5 days of parenteral anticoagulant. So you have to give them some low molecular weight heparin. You can't skip this bit because this is the important early treatment. And then you put them on their treatment doses of either dabigatran or edoxaban. And again, I would encourage you to give the patients the full 3-month treatment. So that's a sort of whistle-stop journey through management of deep vein thrombosis. I'm not going to spend too long on PEs, except just to highlight a couple of important caveats for you. Again, NICE recommend using rivaroxaban and apixaban for patients with pulmonary embolism, and that's in keeping with also the European Society of Cardiology PE guidelines. I'm going to show you a couple of slides and just take a moment, take a breath. They look a little bit daunting when you first look at them, but they can be quite useful in terms of how you manage your PE patients. And the reason why it's important is that historically, PE patients have been admitted to hospital, put on bed rest, and then spent a week or week and a half in hospital. Not all patients need to stay in hospital for their PEs. We can ambulate and send patients home now within 12 to 24 hours. But on average, if I go back 5 years and look at my own health board, my own hospital, the average length of stay was maybe 11 or 12 days. And that's come down significantly because of the risk assessments and the way we anticoagulate patients now. So just take a moment. Don't try and read this and understand it all, but the things that we're just looking at and considering when risk assessing our patients are their hemodynamic stability, something called the PESI score, the Pulmonary Embolism Severity Index. We're looking at the right ventricle. We're looking for RV dysfunction, and that can either be on the CTPA report or on an echo. And sometimes we're doing cardiac troponin markers. So those are 4 things that we're just taking into account when we're assessing which patients to keep in. Okay, so the PESI score, again, you'll find that on your phone, on an app, very easy to calculate. There's a more complicated PESI score, but the simplified PESI score will just look at 6 components. If your patient scores 0, they have a low 30-day mortality risk, and these are the patients that we're considering for ambulation and home early. Okay, so again, this is a final complex slide. This tries to sort of summarize everything in a nutshell for your patient. So you've got a patient and you've diagnosed the P. Obviously, you've got to actually get to Holly's second appointment where she's actually confirmed with her PE. And then she starts anticoagulation. Okay. The first thing you want to do as a junior doctor is just assess the hemodynamic stability of your patient. If they're unstable, they go to the left-hand side on your screen. They are high risk, and the grown-ups will start managing these patients because maybe we're doing clot extraction or thrombolysis or something else. But for everybody else, we want to know, are they low risk, intermediate risk, or somewhere in the middle? Okay. And so for you as junior doctors, what I would suggest is for your stable patients, look at the PESI score. If the PESI score is low risk, go back and have a look at the CTPA report, or if somebody's done an echo, is there any evidence of RV dysfunction? If the answer to any of those is yes, go to the left-hand side, talk to your senior colleagues, consider doing a troponin, consider keeping those patients in for observation. However, if there's no RV dysfunction, PESI score is low, then assess the patient's suitability for being sent home. Do they live alone? Do they have family support? Are they with somebody? You need to make sure there is a secure environment for them to be discharged to. So low PESI score, or PESI score 0, no evidence of RV dysfunction, some social support. These patients can be considered for home discharge. And and I saw a patient who came in, I think Tuesday night, he came in at 3 a.m. And he was discharged basically on the same date and same clock that afternoon, 12 hours in hospital, had his scan, started his anticoagulation, gone home. No need to keep him in hospital for a week. Okay, so just very quickly remind you, same dosing for DVTs and PEs. Rivaroxaban 15 BD for 3 weeks, step down to 20 milligrams daily. Fixbam 10 milligrams twice a day for 7 days, step down to 5 BD. Bigatran and Doxbam, heparin, and then treatment dose. And that's 20 minutes on the spot, Will. So back to you, mate.
That's very impressive to cram that much information in 20 minutes. That's fantastic.
Okay, mate.
What I'm going to suggest in the interest of time is that there are some questions coming up on the chat, Raza, and it would perhaps be good for you to answer those questions on the chat as we're going along, and then obviously those answers. That some of them are very interesting questions about whether you need to still give the whole loading dose if you've had a heparin lead in. So it might.
Yeah, I'll answer those. Yeah, no worries.